Hello, everybody. Aloha. Aloha kako. My name is Dr. Rohinton Patel, and I'd like to start by thanking the John A. Burns School of Medicine and the Rosita Leong Mini Medical School on Healthy Aging for having me here as a visiting lecturer. After several years, I had lectured prior some years ago regarding a different topic in oral and dental medicine. Today, we're going to discuss periodontal disease and how it affects your health at different ages. I am the director of Hawaii Pacific Dental Group located in East Honolulu, Hawaii Kai. As well, I'm an adjunct clinical professor for Boston University School of Dental Medicine. I direct the APEX internship program here in Honolulu, whereby we have usually 4 to 6 dental intern students in their second year of their training program that attend our practice for a few months every year in the summer. And we do a grand rounds every morning and patient care prior for them going back to their campus and treating patients of their own. My office email address is listed on our first and last slide, as well as the office phone number and our address. If there are any questions at any time from any participants, please don't ever hesitate to call us or email us at our practice, and we will be happy to get back to you. A disclaimer, I have no vested nor monetary interests regarding this presentation today. And otherwise, we're going to jump right to this. So what is periodontal disease? Periodontitis, or inflammation of the periodontium, is a serious infectious disease that inflicts the gums, the jawbones, and teeth, resulting inevitably in tooth loss, infection, and degradation of the bone, and bleeding gums. The infection is not necessarily localized to your mouth. It's oftentimes systemic in nature, which can be measured in the blood via elevated blood markers of inflammation. Periodontal disease is a significant risk factor that's been strongly shown that can cause, or a risk factor causing heart and lung diseases, as well as type 2 diabetes mellitus. How common is periodontal disease? Periodontal disease inflicts over 3 million Americans each year. It's a disease that when caught in its early stages, in its infancy, can be halted with quite good success. However, once the treatment is initiated, the oral hygiene and the instructions for care have to be judiciously maintained by the patient. If not, likely relapse will occur. Periodontal disease is usually painless in its initial stages. And unfortunately, it's one of those diseases that's kind of like a silent disease, much like several heart diseases are. And once the damage is done, there's not oftentimes much going back for repairing what has been damaged. A recent CDC report provides data related to the prevalence of periodontitis in the United States. 47.2% of adults aged 30 years and older have some form of this disease. Periodontal disease increases with age. 70.1% of adults aged 65 and older will have or have periodontal disease at some point in their life. So what are the risk factors for developing periodontal disease? First thing is gingivitis, inflammation of your gingiva, a very reversible issue that occurs oftentimes with an inadequate amount of dental hygiene at home, poor oral health habits, smoking or chewing tobacco. Additionally, chewing of the betel quid or the areca nut is very prevalent in South Asian countries and in Asia in general. Hormonal changes, such as those related to pregnancy, menopause, or even hormonal changes related to puberty in our younger patients. Recreational drug use, such as smoking, smoking cigarettes, smoking marijuana, smoking a vapor pen. Obesity, inadequate nutrition, including vitamin C deficiency, and unfortunately, some patients have the risk factor for developing periodontal disease due to genetic predispositions, in which we can't stop. In order to prevent periodontal disease, it is paramount that our patients are recommended biannual professional dental cleanings, whereby the dental hygienist and I will scroll with the mouse on these slides, clean around the roots of your teeth, removing tartar and plaque. This in-case photograph is a very aggressive amount of periodontal gum disease, and we call this a bridge of calculus or calcified plaque, which is basically a biofilm of bacteria. When it gets to this stage, the patient is not necessarily in the best shape. This photograph in particular is an image of a chronic periodontal disease patient, not an acute case, not a recent immediate onset case. Other ways to prevent periodontal disease are by the use of an electric toothbrush, which is found more effective than a manual toothbrush due to the frequency in which the toothbrush bristles vibrate off the softer plaque. And the goal about toothbrushing and toothbrushing often is that we want to remove the biofilm of soft plaque that occurs on all humans' teeth before it can have a chance to harden and turn into that more destructive calculus. We'll get into that a little bit more in detail in a few more slides. And then, of course, something that everyone should be doing every day after every meal is flossing their teeth. Very, very important method of keeping your teeth clean. Removing food particles that are essentially food for bacteria. There are over 400 different types of microflora, different types of bacterial families that live in your mouth at any given time. So as little as we can feed them, the better for them to not proliferate. The image on the slide that I'm pointing to here is an image of a water pick, which is basically a pressurized device that shoots a stream of water that helps dislodge plaque in the areas that the toothbrush bristles alone cannot get. Toothbrush bristles effectively clean about 2 to 3 millimeters around the free band of gum tissue, which we'll discuss in a few moments when we get to a later slide regarding the anatomy and physiology of your gums. More symptoms of periodontal disease according to the mayoclinic.com. Swollen or puffy gums, bright red, dusky red, or purplish gums. The latter, purplish gums, a very bad sign of a lack of blood flow and ischemia, or lack of oxygenated blood going to the environment. Gums that feel tender when they're touched are a sign of disease. Gums that bleed easily are a sign of disease. Pink tinged toothbrush that you look at after you take it out of your mouth from brushing your teeth is a sign that bleeding has occurred, something again to report to your dental physician, your dentist immediately. Spitting out blood when brushing and flossing your teeth. Bad breath, halitosis we call it, is a sign of periodontal disease. Fetid metallic odor is most commonly associated with periodontal disease due to the bacterial makeup in the shell of calculus that's around the gums and roots of your teeth. And lastly, another bad thing that we do not like to see is pus separation between your gums and teeth. Preventive steps to avoid and maintain a disease-free oral environment, of course, is brushing your teeth twice a day, or if you're so inclined, able to do so after every meal and snack you eat. Again, the goal is to keep the food particles, the carbohydrates and the sugar-rich foods that we eat away from the bacteria so they don't have as much of a chance to proliferate as successfully. We always advocate our patients to use a soft, or even better, an extra soft bristled head toothbrush, be it via manual brush or better, an electric toothbrush head, and changing the brush head every 3 months at a minimum. We again strongly ask our patients to consider using an electric toothbrush, which is more effective at removing plaque and then, of course, the harder tartar that plaque can develop into. Flossing and a mouth rinse is also helpful. There are prescription mouth rinses available. Chlorhexidine gluconate, it's a soap that surgeons scrub up with in the operating rooms of hospitals. We have a suspension rinse at a much lower percentage, 0.12%, that's often prescribed in dental practices for patients with past periodontal disease or current periodontal disease, oftentimes advocated in the use of a water pick. We have our patients dilute a solution and irrigate their gums with that diluted chlorhexidine rinse with water in the water pick every night before bed. It's been shown to have good effect. Supplemental brushing and flossing with an interdental cleaner, such as a dental pick or an interdental brush, a dental stick specially designed to clean between your teeth, I'd recommend all the patients here, all people here, seek approval by their dentist regarding what types of supplemental brushing and flossing cleaners they should be using, mostly because a lot of patients have some more significant dental restorations that could be undermined by more aggressive supplemental tools. Of course, getting regular professional dental cleanings on a schedule recommended by our dentist, healthy subjects twice a year, biannual every 6-month cleaning. It's been shown, American Academy of Periodontology and the American Dental Association, that a soft plaque biofilm will harden over a 6-month period of time. That's why the recommendation is for every 6 months to have that plaque and tartar debrided from your gum tissue at your professional dental prophylaxis cleaning with your dental hygienist or your dentist. Patients with periodontal disease, oftentimes mild to moderate disease, will usually get a cleaning every 4 months. And patients with severe disease will get cleanings every quarter, every 3 months. Patients that have periodontal disease and have limited mobility and function to take care of their teeth, be it to a medical fragility, we recommend sometimes patients coming in as often as 1 or 2 months. The biggest risk factor, again, to prevent and maintain a disease-free oral environment is to not smoke and not chew tobacco or betel nut, areca nut. Okay, we're going to get to the anatomy of what the periodontium actually is. The periodontium is not just the gum tissue, the pink gum tissue we see in our mouth. It's comprised of many other structures that make the entire apparatus. It's a very important apparatus that's heavily innervated by the blood in our bodies, the same blood that goes to the rest of your body via circulation, your heart, your brain, your kidneys, your lungs, everything is the same blood that goes to your jawbones. So the issue of periodontal disease becomes very important because it's a very intimate area that allows an entrance, as I'm pointing with my cursory mouse here, to the bloodstream. This is an anatomic slide, a depiction of the tooth. The shell on the outside is the enamel, or the clinical crown of the tooth that we see when we smile, when we open our mouth. It's the white part of your tooth. That's called the enamel. It's a couple of millimeters thick, and it's the hardest substance in our body. Second hardest substance in our body is dentin, the bodily structure that makes a majority, 90% of your tooth structure. It's contained of tubules that have a fluid in them called dentinal fluid, and they communicate with the pulpal chamber and vascularity in the nerve and pulp of your tooth's root system. Oftentimes, when your tooth becomes infected either via a caries cavity in your tooth or a periodontal infection that's close to the entrance and exit of where the vasculature enters the root of your tooth, called the apex, or the tip of the root of the tooth can degenerate and die off, causing an infection or an abscess to develop right in this region of where I'm circling with my mouse. The bony structures that make up the periodontium consist of the bony socket that the roots of our teeth are embedded in our jaws, called the alveolar socket. So basically, the teeth in our mouths are not joined to the jawbone. They essentially float in our jawbone, and they're attached by a ligament, a muscular attachment, called a periodontal ligament. The ligament is comprised of 5 different types of fibers: the intraradicular fiber, the alveolar crestal fiber, horizontal, oblique, apical, and circumferential fibers. Some of those fibers are important when we're orthodontically moving your teeth, in which case, if the orthodontics is oftentimes done too fast, periodontal disease can occur due to injury of one of the fibers in that ligament. Additionally, the crest of bone, the hardened or corticated dense crest of bone that immediately surrounds the root of our teeth, is called the lamina dura. It's something that we measure in your dental radiographs we take annually, or sometimes more often, more frequently. And within the jawbone itself are these haversian canals in something called trabecular bone. All those little holes and areas and voids we're seeing in this photograph are areas of where blood is innervating your jaw. So we can start to kind of get an idea where we see plaque and bacteria and tartar building up around the edge of your tooth working its way down closer to the area of your bloodstream. So essentially, periodontal disease is your body's healthy immune response being surmounted against an inflicting insulting agent, that agent being plaque and tartar. And unless it's correctly debrided out of the infected area, your body will move its bone away from the diseased area. The periodontal ligament attaches to the bony structure called the lamina dura, to the root of your tooth, to a material in the root of the tooth called cementum. When bacteria get in this area and start causing inflammation and giving off toxins produced by mostly oxygen-depleted bacteria environments, they are called gram-negative bacteria. They're the worst kind. They exist mostly in tartar, not as much in plaque. The infectious agents start attaching and adhering to the cementum of your tooth. So those have to be cleaned. The primary functions of the periodontium are to allow the tooth to be attached to the bone and provide a barrier for the underlying structures from the oral microflora. So it's basically our mouth's defense mechanism to prevent bacteria getting into our bloodstream or our jaws. These are a couple of images of a healthy periodontium. The coral bright pink color is what we like to see in optimal health. We would like to see a knife edge, sharp, fine, definitive point in the triangular portion of the gum tissue that's located in between the contact of every tooth, assuming the teeth are contacting correctly. This triangular tissue is called the papilla. The papilla is the best sign for patients to examine themselves in the mirror daily. If you see signs in the color or in the anatomy of your papilla other than a knife edge or a bright coral pink color that's not bleeding, that's a sign that perhaps an inflammation is locally occurring, and you should bring that to your dentist's attention. Certain patients with darker complexions and darker pigmentation can have a darker amount of gingiva. However, the coral pink nature of the sulcus of the gum tissue, the immediate free gum tissue that surrounds the necks and the roots of our teeth, will have this very similar color. Signs of periodontal disease. They are classified in stages, and I have some animated depictions on the left of your screen and some color depictions on the right of your screen. Again, in a healthy individual, you will have an intact alveolar crest of bone in between adjacent teeth, followed by a gingival tissue attachment of around 3 millimeters in thickness. This depth of where the crown or the enamel of your tooth that you see that just begins at your gum tissue to the base of the sulcus of where the attachment stops is what's measured when you get your routine dental cleanings, your routine dental prophylaxis. We measure this twice a year. 2 to 3 millimeters is the optimal health probing depth of top of the gingiva to the bottom of the sulcus, the bottom of the depth of that pocketing area. When the area becomes infected, we have something called a pseudopocket. The gums become inflamed and enlarged, so our periodontal probe will measure a little bit larger. Around 4 millimeters of depth is a sign of moderate gingivitis. If the disease is left untreated from gingivitis, the bacterial population again turns into a more aggressive type and hardens or calcifies, or otherwise known as calculus. And the bone starts to resorb away because the toxins in the calculus send markers into your bloodstream that cause it to move away from the insulting agent. As the bone moves away, a double-edged sword happens. We now have a larger potential space for more plaque and bacteria to occur. So the disease left unaddressed will continue to be aggressive and destructive, considering more loss of bone, eventually causing teeth to become loose and the infectious agents to become more virulent. The images on your right-hand side, this one that I'm circling right here, is a sign of acute gingivitis because it's located only on a couple of teeth, not throughout the mouth. The first thing I look at on this slide is that the teeth are not touching interproximally, meaning in between each other. These two teeth are crowned, and the patient had something dislodged, never got it treated over time, caused movement of the teeth. Your teeth will move and can shift with advanced disease. A patient that has something like this occur will look to types of treatment to close the issue, close the space that's developed here, either orthodontics or dental bonding to close the gap and not prevent as much food getting, to prevent more food getting into the area. The slide that I'm circling here is gum disease and periodontal disease caused by sequela of a certain drug called phenytoin. Patients with seizures can be oftentimes prescribed this drug and have an acute nature. This unfortunately has to be resected away after the drug therapy is stopped. This is an image here of a periodontal probe probing into the depth of the sulcus of the gum tissue. In this image here, we are showing something of advanced periodontitis because the probing depth is going about 6 to 7 millimeters deep. If the probing depth is past about 7 to 8 millimeters, the nature of how the tooth can survive goes down. We don't have that great of a success rate. There are nice modalities that have come about in recent technological advancements, mostly via the use of lasers in a procedure called LANAP, laser-guided surgery, in which ways we can regenerate some epithelial or soft connective tissue to grow back. However, the bone does not grow back unless it's replaced via a bone graft. We'll talk about that in a few slides. Okay, so stages of gum disease. This is health, coral pink. We have a great bony attachment around the roots of your teeth. These are evidenced by your dental radiographs your dentist takes every year. Signs of inflammation and disease. We look at the darkened, reddened area, perhaps a little bit of bleeding, tartar building up around the teeth and the gums. The next stage is periodontitis, mild, moderate to severe, in which case the plaque has not been removed, it's been left there, and the bacteria causing the insulting agent causes the bone to degrade downwards, apically towards the roots of your teeth, and a pocket develops. After the inflammation causes the tooth to form pockets, it leads to advanced periodontitis or advanced disease, resulting in severe bone loss and an erratic surface of bone, not the sharp, nice, rounded, blunt point here that we see in optimal health. The tooth is in danger at this point of being lost. What do stages of periodontal disease look like? Again, a few slides showing healthy gums, the coral bright pink, right around the necks of the teeth. We're not looking higher up here in the connective tissue. That's where pigmentation has an effect. We're looking directly at the root of the neck of the tooth, right around where the root meets the enamel, or the dentin meets the enamel. The roots of our teeth do not contain enamel. Only the crown, the clinical crown portion that we see in the mouth is what contains enamel. When you have erosion and destruction of the alveolar bone that surrounds the root of your teeth, destruction of the periodontal apparatus, we have loss of bone, and the roots become exposed. When the roots become exposed, we start seeing these cavernous areas housing more tartar and plaque because they're much more difficult to maintain and keep clean with proper oral hygiene and dentifrice. A couple of images of a normal tooth versus an infected tooth. Healthy gums in the alveolar socket of bone. Coral pink, healthy bone level we want to see ending about 2.5 to 3 millimeters from where the shell of your enamel ends. That's called the appropriate biological width. And that's what we measure when we do your dental x-rays. That's what we measure when we do your dental prophylaxis cleaning by the periodontal probing. We want to see this healthy level here. When we see a loss of biological width, it's due to the disease and a deepening pocket. This slide, for example, shows something called a furcational involvement on your molars, multi-rooted teeth, where the roots bifurcate or split. Plaque can begin to lodge in the area of bifurcation, the area of where the roots split and diverge. That is unfortunately a very difficult place to maintain and keep clean. Periodontitis occurs in all ages, not as commonly in juvenile stages, however it does, in which case we see aggressive bone loss on this radiograph. This radiograph X-ray is a two-dimensional picture of your tooth. The bright white shell I'm scoring here is your enamel. The majority of your tooth is your root, right here. The clinical crown that we see in the mouth ends right about here. That's the enamel of your tooth. And the bony structure that's lost should be about 2.5 millimeters, 2.7 millimeters from where the enamel ends to where the crest of your jaw begins. In this patient's case, in slide C of juvenile periodontitis, the bone has completely shrunken away. Excuse me. We see in this picture, we are lacking as much a knife edge. It's more of a blunted, rounded, inflamed area around the gum tissue at the papilla. Again, a sign of disease. In adult periodontitis, oftentimes much more of a chronic, long-standing disease. It didn't happen overnight. It takes time for periodontal disease to happen. We have exposure of your root surfaces with the cementum. That's fine particles of cement. It almost looks like that on a microscope. Very adherent to plaque and bacteria. And they grow. And in this case, we have suppuration and pus developing around the gum area. We have loss of bone. We don't have that knife edge papilla anymore. The teeth have started to become loose and mobile. And we have a great amount of disease at this point. In a case like this, there may not be much saving your teeth. And the disease markers in the bloodstream, the inflammatory markers in the bloodstream can be measured as well. There are a couple of ways that we treat periodontal disease. There's a surgical approach and a non-surgical approach. If we treat via a non-surgical approach, we mean in the dental practice. If the disease is not as advanced, treatment involves less invasive procedures such as a dental prophylaxis that can simply remove the plaque and tartar, the etiologic or infective agents. Other less invasive procedures are inclusive of something called scaling and root planing. Scaling removes the tartar and bacteria from the tooth surface just beneath your gums. It's performed using instruments or lasers, and an ultrasonic device called a cavitron, which vibrates at a high frequency the plaque and tartar, much like an electric toothbrush does, however, at a much higher frequency off of the teeth. Root planing, once the plaque and tartar have gone down to the root surface of your teeth, the plaque and tartar need to be planed off the roots with very sharp instruments, removing the plaque and tartar from the cementum. You are unfortunately also removing the cementum from the tooth's anatomical structure. Hence, you don't have a correct attachment ever again once it's been planed. Therapy to do all these things help reduce the pocket depth, and that is the inevitable goal. Periodontal disease, once its destruction is done, cannot be brought back, bone cannot be brought back, but we can halt the disease state and we can prevent it from progressing further. Antibiotics can be given either topically, placed in the region of the sulcus. There is an antibiotic called Arrestin, it's minocycline. It's placed in little microscopic spheres and delivered by an injection. It's a powder placed in the depth of the bone by where the root is infected, and it's a release capsule medication over a 10-day period your dentist has to place individually per surface of tooth. There are 6 different surfaces of the tooth, 3 on the outer buccal cheek side surface, and 3 on the lingual or palatal surface, the tongue side surface of your tooth. Oral systemic antibiotics can also be prescribed to help control infections. Topical antibiotics include additional antibiotic mouth rinses, insertion of gels. However, oral antibiotics may be necessary to completely eliminate infection causing bacteria once they are in the bloodstream. Surgical treatment approach is then taken if a non-surgical approach is ineffective. If you have advanced periodontitis, treatment requires dental surgery, oftentimes, called pocket elimination, where they open a flap of your gum tissue and reduce the size of pocket by flattening out that erratic bone at the crest that's been damaged by the infection. We lift the gum back, we expose the roots so we can clearly see where the problem areas, the etiologic infective agents are, and we can remove them. Because periodontitis affects bone loss, the underlying bone may be recontoured before the gums then are sutured back in place. After you heal, it'll be easier to clean. However, you will have large spaces in between your teeth because those infected roots that were covered by very large amounts of inflamed gum tissue have receded back down. They can be coral pink in color and healthy, not ischemic, not lacking the oxygenated blood they need. However, the destruction is done. So the teeth can sometimes become mobile and loose. Additionally, we have something called soft tissue gum grafts. For patients that have gums that have receded away in certain locations, we can harvest the gum from the palate of your jaw and something called a free gingival gum graft and transplant it on to the gum tissue. It is sometimes not as cosmetic in nature due to the adipose fatty nature of the tissue being transplanted. Bone grafting can occur and can be done. It's not always extremely successful because we don't have the attachment left anymore on the cementum of the root once the disease has started. The graft can be taken and harvested from your own jaw, small fragments of your own bone, oftentimes mixed with something called PRP or platelet-rich plasma, in which case we draw a vial of blood and centrifuge down the clotting proteins of your blood, and we mix that into the bone structure and graft it in place. We can also use synthetic cadaveric or human bovine bones are also used for these types of grafting procedures. Guided tissue regeneration is another procedure that allows us to regrow the bone due to destroyed bacteria. In one approach, we place a biocompatible fabric between the bone and the tooth. It helps to regenerate. It's not always successful. The material, however, prevents unwanted tissue from entering into the healing area. So oftentimes once a bone graft is attempted, it is covered by a membrane that doesn't allow the soft gum tissue to grow into the area we want bone to develop into. It is a technique we also use in patients that are missing teeth. We want to rehabilitate or give them back a tooth via a dental implant. We will use bone grafting and guided tissue regeneration. Excuse me. Another surgical approach, which is not as common, are to use tissue stimulating proteins involving applying a special gel to the diseased root tooth that inevitably stimulates the growth of healthy bone tissue. Pardon me. What do I do after I have lost a tooth due to periodontal disease? Well, there are not a lot of options once the bone is lost. And dental implants and/or removable dentures are the only option to replace missing teeth. A fixed denture is sometimes an option if the surrounding teeth around an adjacent missing space are available and strong enough to support. So thereby you don't have to remove your denture every day. They're fixed on to your adjacent teeth. Your adjacent teeth have to be ground down. The enamel has to be removed in order for the appliance to set. And it's a type of prosthetic that needs to be changed on average every decade, sometimes longer, sometimes less, depending on the oral care, genetic predisposition to developing caries and disease, as well as the type of foods patients eating and any parafunctional habits such as clenching and grinding of the teeth, which can inevitably also be a risk factor for periodontal disease. Clenching and grinding of your teeth, otherwise known as bruxism, is a very common malady afflicting a lot of humans in our population. If you know you do it, the recommendation is for our patients to have a protective splint called a mouth guard that helps prevent some of the deleterious effects from that parafunctional habit, not all of them. In this case, the patient had advanced periodontal disease and bone loss, the bone only covering about 1/3 of the root. In an ideal clinical situation, the bone of your jaw should be covering 2/3 of the root, leaving exposed only 1/3 of the tooth surface as the clinical crown above the healthy gum line. When we have an immense amount of bone loss, the teeth become mobile and loose, much akin to the analogy of having a post peered down in cement versus a post peered down in sand, with a little cement at the tip. A healthy bone would be a post poured into cement covering 2/3 of the post, exposing 1/3 of the top of the post. A post in disease state would be a post being covered in barely 1/3 of cement, the rest of it in a sandy mix that's very loose. So the functions of chewing, mastication, grinding, and clenching will inevitably cause the teeth to mechanically loosen, even if the disease has been stopped. Dental implants are a 3-piece system per root of a tooth. It consists of oftentimes a titanium root that's screwed into the jawbone, assuming the patient has adequate jawbone. If they do not, we often have to move the membranes out of the way or the vital structures out of the way via grafting or lifting techniques, and additionally adding synthetic jawbone to the region, allowing adequate time for the bone to heal and grow, 4 to 6 months on average on a successful bone graft and augmentation. And then the root goes and screws in place with a good torquing strength. Once this titanium root, which stops right about here, is placed into the tooth, the bone has to grow around the threads of that titanium screw. So for an example, this is a patient without a tooth in this animated image here. This is the dental implant, the titanium screw, taking place inside the jawbone. Right here, this is the titanium screw. Once the bone has integrated and has been tested successfully, we load the implant, 4 to 6 months on average waiting time, with something called an abutment, which basically sticks halfway out of the gum and locks into the hollow root of the dental implant with another screw. And then the crown that's cemented or oftentimes screwed on top of the implant abutment combination. In dental implantology, often the last stage of rehabilitating our missing teeth, oftentimes due to bone loss and gum disease, consists in our practice in a certain methodology. We do a pre-surgery workup, which is taking a 3-dimensional cone beam CAT scan, a computed tomograph, which shows the density and width and length and height and porosities and all the vital structures of your jaw bones. We do digital diagnostic models of your jaws via a camera. We merge both the camera model of your teeth onto the CAT scan, and we design and have a 3D printed surgical guide fabricated based on all that digital data. We then do your surgery digitally on the screen, and we have the laboratories fabricate us back a guide that mimics your surgery day before we even start. On the day of surgery, we use the surgical guide, which looks like this mouthpiece here, and it fits directly over your teeth. It has a little guide key that allows my drills that go into the bone to create the space for your implant to not exceed the certain length, the certain width, or the certain direction. It's exactly like I plan it on the CAT scan. The brand of CAT scan we have is considered the best in the industry. Is called a Galileos. It's a multi-volume cone beam CAT scan that allows us with great precision to place a dental implant with minimal problems down the road. Once the implant is placed, it's very minimal pain. It's a very minimally invasive technique in which we do not need to flap open the entire gum tissue. We just place the mouth guide and do a tissue punch to remove a little bit of the jaw's gum tissue in the area where the implant is going in. We create the osteotomy, or the hole in which the screw goes into place, and then we torque the screw in. So a lot of planning prior to the patient's surgery. The surgeries only take 10 to 20 minutes, and most patients do pretty well with just an over-the-counter Tylenol. The best case scenario, we ask our patients at their 1-week follow-up examination, is there any pain? And we want to hear a resounding no, I don't feel anything. And that's a good sign that your bone is on its way to integrating your dental implant. The restorative phase then again is to load the titanium implant that's been integrated successfully in the jawbone with an abutment and crown. In our practice, we make our crowns in the office as well in a single visit with 3D technologies and a CAD-CAM 3D printed technology, which was in my lecture for the School of Medicine at UH several years back. In closing remarks, again, we discussed periodontal disease, its effects at different stages, the ways it can be prevented, the ways it's caused, the risk factors for it. And I'd like to open up at this point for any questions and answers. I'll be free to answer here, or again, feel free to email or call at our practice at any time. Again, I thank the John A. Burns School of Medicine at the University of Hawaii and the Rosita Leong Mini Medical School for having me as a visiting faculty lecturer, and look forward to your questions and answers. Thank you.